Mm.
Could you please confirm?
Yes, it's visible.
Yeah. Thank you. You already known about well versed with regarding this eye-related anatomy and physiology. What are the eye effects? So, glaucoma is a major disorder nowadays. Glaucoma is nothing but it's a group of eye disease. Simply, we can call as intraocular pressure. There, our eyes secreted aqueous humor from ciliary bodies. Normal, there will be some pressure. That normal pressure is less than 10 mm of Hg, like our hypertension, 120 by 80 mm of Hg. Like that, this is less than 10 mm of Hg is considered as normal pressure in the eye. If more than 20 mm of Hg, it will consider as intraocular pressure. So what it will happen here, if you talk about pathophysiology, ciliary bodies will produce the aqueous humor. There will be any blockage or any debris will form in the ciliary bodies, that aqueous production will hamper. So if it is blockage will happen, the more aqueous humor will stick or float into the ciliary bodies. There will be some pressure kind of will be happen. That pressure is called as intraocular pressure. Intra means within, inter means in between. So that pressure, what we have to do, either that production we need to reduce, or whatever coming into the fluid into the ciliary body, we have to secrete outside, means we have to pump outside. So what we have to do, we have two medication, either secretory drainage we have to stop, or else we have to that fluid we have to come out. So what we have two kinds of medications. For that secretory drainage, we alpha adrenergic agonist, beta blockers, and diuretics. These are the three class for secretory drainage. So alpha adrenergic blocker, what will happen? Dipivefrin, apraclidine, brimonidine. They increase the, they will act on noradrenaline. What it will do? It will stop that secretory drainage because of adrenergic systems are cause mydriasis. There, whenever mydriasis will happen, the vasodilation will happen. Beta adrenergic blockers, what it will do? That adrenergic actions, it will stop at the beta receptors. Timolol, betaxolol, levobunolol, cartilol, these are the different drugs. What this trabecular pathway and uveoscleral pathway will do? These prostaglandins, latanoprost, bromatoprost, it will act on that uveoscleral pathway. The secretory outcome, the fluid come out easily. These are the miotics, pilocarpine, physostigma, ecothiophyte. These act as cholinergic agonist. These miotics all are cholinergic agonist. It will cause the constriction of pupil. Whenever constriction of pupil will happen, the secretory drainage also will stop. This is, and we have different types of glaucoma also. Open angle glaucoma, closed angle glaucoma. It increase, that is called as open angle glaucoma. The degree iris and cornea will reduce. That is called as closed angle glaucoma. This is the medication for about glaucoma. The next topic is antibacterial. What is antibacterial? You all know anti-agonist. Bacteria is bacteria. These are the drugs which act against bacteria. There will be two types: bacteriostatic, bactericidal. What is bacteriostatic? The agents which stop or inhibit the growth of bacteria is called bacteriostatic. Bactericidal means suicide. We can call sui means ourselves, sidal means killing. Like that, bactericidal. The agents which killing the bacteria, those are called as bactericidal. If you talk about bacteria, two types of bacteria we have: gram positive bacteria, gram negative bacteria. If you talk about gram positive bacteria, you can keep it as a mnemonic PPT. It having cell wall, peptidoglycan, very thick layer. It is called as teichoic acid. And if you talk about gram negative bacteria, very thin cell wall, you can easily disturb the cell wall. So the major how to identify the bacteria, gram positive and gram negative. We have that gram staining, crystal violet, gram iodine, ethyl alcohol, saffronin. This is the steps you have to do. There will be a purple will come, that is gram positive bacteria. If it will come as a red color, you can call it as gram negative bacteria. So if you there will be a classification of drugs: cell wall synthesis inhibitors, cell membrane inhibitors, protein synthesis inhibitors, and metabolic DNA synthesis inhibitor. Some of the metabolic act against metabolic pathways. So if you talk about cell wall synthesis inhibitors, if you see here, These are the cell wall synthesis inhibitors, penicillins, monobactams, cephalosporins, carbapenems, glycopeptides, bacitracin. So if you talk about cell wall synthesis inhibitor, there will be beta lactams. It having beta lactamase ring. What does penicillin, what these all will do? It will bind to the cell wall. There will be one enzyme, transpeptidase. Whenever this drug will bind to that transpeptidase enzyme, cell wall synthesis will arrest. So cell wall synthesis will happen. Bacteria will die. And another one is glycopeptide, vancomycin. You all about know this vancomycin. Methicillin resistant staphylococcus aureus. This is the wonderful drug for MRSA, which causes the Redman syndrome. And if you have different types of penicillins, penicillin, acid resistant penicillins, amino penicillins, carboxypenicillin, carindacillin, like ticarcillin, and one of class is there, beta lactamase inhibitor. Those are clavulanic acid, sulbactam, tazobactam. There will be a one drug, augmentin. That brand name is augmentin. There is a combination of clavulanic acid and amoxicillin. That is the best suitable antibacterial for children's as well as any nosocomial infections, as well as cephalosporins also. Cephalosporins mostly used in nosocomial infections. And plasma membrane inhibitors, polymyxin, colistin, lipopeptide, daptomycin. These are the plasma membrane inhibitors. If we people all about know central dogma of life, DNA to RNA, RNA to protein. DNA to RNA we called as transcription. RNA to protein we called as translation. So if you talk about, we have two types of proteins, like 30s ribosomal subunits, 50s ribosomal subunits. If these are the 70s ribosomal units present in bacteria, in humans 80s ribosomal subunits. If you talk about ribosomal subunits, 30s ribosomal subunits, aminoglycosides and tetracyclines. If you talk about 50s ribosomal subunit inhibitors are macrolides, lincosamide, chloramphenicol, oxazolidine diones. Oxazolidine diones, the best drug is linezolid. If you talk about aminoglycosides, the wonderful drug is streptomycin, tobramycin, kanamycin, gentamicin. This aminoglycoside, streptomycin, having different adverse effect, that is called ototoxic, nephrotoxic, neurotoxic. These are the major adverse effects for aminoglycosides. And if you talk about tetracyclines will cause the yellow color teeth. Coming to the DNA synthesis inhibitors, we have different types of quinolines. In among the different types of quinolines, we will study about fluoroquinolines, ciprofloxacin, levofloxacin, moxifloxacin. If you see about market, most of the times we will get ciprofloxacin eye drops. Then RNA synthesis inhibitors, rifamycin, rifampicin, rifabutin. These are the different class of drugs. And finally, metabolic pathway inhibitor, folic acid synthesis. Folic acid, how it will form? PABA, para-amino benzoic acid, converted to pteridine, then converted to dihydrofolate, then converted to folic acid. Whenever these drugs bind to the plasma bacterial DHFR, dihydrofolate reductase enzyme, these all synthesis will happen. So DNA and RNA does not form, protein doesn't form. These are the different types of drugs. See, whatever we discussed about previous slide, these are all same class of drugs: cell wall synthesis inhibitor, protein synthesis inhibitors, and mRNA inhibitor like aminoglycosides. These are all the same drugs. And if you talk about sulfonamides, sulfonamides are the first earliest known drugs for antibacterial. There will be one drug is the prontosilrate. That is the prototype drug for sulfonamides. From that we got rest kind of drugs: sulfadiazine, sulfamethoxazole, sulfadoxine, and sulfacetamide particularly used for treatment of eye infections, and silver sulfadiazine to treat for burns. Among these all drugs, these sulfonamides major adverse effect is pus forming drugs. These drugs will causes the hypersensitivity. You know hypersensitivity all. Hypersensitivity means allergic reaction, flush, wheal, flare, itching, urticaria. Then these sulfonamides will cause the triple response kind of things. And antibiotics mainly adverse effect is cationic toxicity. Why? Because these antibiotics in the form of cationic salts. If you more take antibacterials or antibiotics, you causes the cationic toxicity due to having high amount of cationic salts. and quinine antimicrobials, nalidic acid, and these levofloxacin, moxifloxacin, we already discussed. Same, what these fluoroquinolines will do, DNA gyrase inhibitor, topoisomerase 2. Whenever this topoisomerase inhibited these kind of fluoroquinolines, the rest of the step DNA to RNA, RNA to protein will stop. These are the special type of bacterial infections in eye. If you talk about acute bacterial conjunctivitis, Haemophilus influenza will cause. The signs and symptoms are inflammation of conjunctiva with purulent discharge. Transmission, how it will transmit? Exposure to secretions from infected individuals. And antimicrobial, these are the broad spectrum topical antibiotics. Whatever is told, cephalosporins or monobactams, carbapenems, penicillins, these are all broad spectrum. Broad spectrum means it will gram positive and gram negative. Narrow means only will particularly either gram positive or gram negative. And bacterial keratitis. Bacterial keratitis mostly caused in Staphylococcus epidermidis and Pseudomonas aeruginosa. If you talk about Pseudomonas aeruginosa, the best drug is ceftazidime. We are working in the lab also that the ceftazidime most against for this Pseudomonas aeruginosa, and Staphylococcus aureus cefazolin is the best drug. It will causes the redness and irritation of the eye, blurred vision. How to transmit? It transmit from pathogen to contaminated contact lens. The antibiotic eye drops, the specifically fluoroquinolones. And a neonatal conjunctivitis, chlamydia trachomatis, and Neisseria gonorrhea. These are the causative organisms. What are the signs and symptoms? Inflammation of conjunctiva, purulent discharge, scarring, perforation of cornea. And the main antibacterial drug, antimicrobial drug is erythromycin. Erythromycin, clarithromycin, azithromycin. These are the best drugs for neonatal conjunctivitis. And the trachoma also called as granular conjunctivitis. It will cause, pathogen is chlamydia trachomatis. It will cause signs and symptoms are chronic conjunctivitis, trichiasis, scarring, and blindness. How it will transmit? Contact with infected individuals or contaminated fomites, transmission to seeking for flies. The main drug is azithromycin. These are different types of bacterial infections to the eye. If you see any marketed formulation present in the market like Besvans, Siloxone, these are all the brand names. If you talk about generic names, Besifloxacin, Ciprofloxacin, what are the percentages, Levofloxacin, Ofloxacin, these are all the different types of drugs with different brand names and which company is going to manufacture which, whether suspension or solution or whatever it may be, means which kind of formulation. And the for pediatric use especially less than greater than 1 year, greater than 1 year, greater than or equal to 6 years. Based on that, fluoroquinolones, aminoglycosides, polymyxin, other antibiotics. This is the list. If you go through the website also, there will be a PubMed or any CDSCO. You will get in ESFDA also. What are the eye drops we are available? What are the formulation? These are the different types. The next one is antifungals. You all about knows these are the agents which act against fungus. See how fungal cell wall made of. Fungal cell wall made of chitin. How it will form? The fungal formation is squalene to lanosterol. If you see here, the squalene to lanosterol, lanosterol to ergosterol. There will be two enzymes here. Squalene to lanosterol, squalene epoxidase enzyme is there. Lanosterol to ergosterol, alpha demethylase enzyme is there for the formation of fungal cell wall. What we have to do majorly here? Either we have to inhibit that enzyme squalene epoxidase or we have to inhibit that 14 alpha demethylase enzyme. So it will stop that production of ergosterol. Finally, cell wall synthesis will be stopped. So these are the drugs here only. If you talk about allyl amines like terbinafine, naftifine, these will inhibit the squalene epoxidase. If you talk about azoles, we have two types of azoles, imidazoles and triazoles. Imidazoles having clotrimazole, miconazole, iconazole. These are the different types of imidazoles. Among all imidazoles, ketoconazole is the systemic drug. And if you talk about triazoles, fluconazole, voriconazole, itraconazole. Among all fungus, Aspergillus flavus, it will causes the fungal keratitis. The drug, wonderful drug or best suitable drug for fungal keratitis, voriconazole. This is the triazole derivative. And if you talk about polyenes, mm, just a minute. Polyene antibiotics are nystatin, and DNA synthesis inhibitors are fluoropyrimidines. These are the different types of drugs used in the used as antifungals, and microtubules inhibitors are griseofulvin. If you see in here classification, what are the different types of antibiotics used in antifungals, antimetabolites? Azole, I already mentioned you the what are the topical azoles and what is the systemic azoles. These alloy elements will act on squalene epoxidase. These azoles will act on alpha demethylase enzyme. If you talk about any topical agents like tolnaftate, andecyclinic acid, and benzoic acid, these are the different class of antifungals. Antifungals used in ophthalmic surgery. These are the which disease, which type of medication we are required. Natamycin 5% you will use for filamentous fungus. One is Fusarium and Aspergillus, and amphotericin for Yeastidae and Candida. Yeast and Candida. What is the disease condition? Deep stated yeast keratitis and immunocompromised patients. If you talk about azoles like triazole, voriconazole, fluconazole, this voriconazole is broad spectrum, filamentous and yeast, deep stromal keratitis, and highly effective for aspergillus and some of the cases resistant to natamycin. If you talk about fluconazole, we will use fluconazole is very low percentage, 0.2%. Why? Because this fluconazole, all triazole derivatives will cross the triple B. That's why we will use very less concentration. Primarily for this fluconazole candida, less common topically. The triple B blood-brain barrier. The blood-brain barrier having endothelial cells, it, it is highly lipophilic. These triazoles are highly lipophilic. The brain easily enter in through highly lipophilic drugs only. That's why these fluconazole having highly lipid metabolism of redistribution also. If you talk about pyrimidines, flucytosine, the target organism is Candida and Cryptococcus. If talk about echinocandin, caspofungin and mycofungin, this is against multi-drug resistant Candida and Aspergillus. The disease condition is refractory keratitis. Now antivirals. We have viruses different among this bacteria and fungi. There will be a how virus will replicate. Whenever any kind of virus will attach, then it will attach to the fusion like endocytosis mechanism or phagocytosis mechanism. Sorry, phagocytosis or phagocytosis. What is phagocytosis? Cell eating is phagocytosis, cell drinking is pinocytosis. There will be seven steps: attachment, fusion, and early encaps, and viral replication, and viral protein synthesis. Finally, viral variant coming out, that is release. If you how the virus is releasing, you can see this is the image, attachment, fusion to up to release. We have different types of herpes simplex virus, varicella zoster virus, cytomegalovirus. We have different types of classes of drugs, antiviral drugs. Like anti-herpes virus drugs are acyclovir, fanciclovir, ganciclovir, idoxuridine. These are the class of drugs. If you talk about anti-influenza drugs, amantadine, rimantadine, oseltamivir, janamivir, and palavizumab. If you talk about these amantadine and rimantadine, these are viral uncoating inhibitors, and oseltamivir, janamivir, viral neuraminidase inhibitor. If you talk about palavizumab, this is specifically used in respiratory syncytial virus. Anti-hepatitis nucleotide reverse transcriptase inhibitors and non-nucleotide reverse transcriptase inhibitors and protease inhibitors. Nucleoside reverse transcriptase are judovidine, lamivudine, stavudine, and non-nucleotides are nevirapine, delavirdine, efavirenz. If you talk about protease inhibitor, ritonavir, indinavir, saquinavir, and entry inhibitor, that is CC enfuvirtide, and CCR5 inhibitors are maravirac, and integrase inhibitors are raltegravir, dolutegravir. These are the different class of antiretroviral drugs. Now, anti-amoebics. Anti-amoebics are drugs which act against amoebic dysentery. This we have different types: luminal amoebicides, tissue amoebicide, and mixed acting. This tissue luminal amoebicides are amides like amide derivatives. In the structure, C11O NH2 is there. That's why they mentioned as amide derivatives. Dioxanide, furoate, and nitroxygen. Antibiotics are tetracycline, paramomycin, and tetrahydroxyquinolines are quinidochlor and dihydroxyquin. If you talk about tissue amoebicide, nitroimidazoles and alkaloids, metronidazole, tinidazole. Metronidazole is the best prototype drug for amoebic dysentery.
So in ocular condition, we have acanthamoeba keratitis, where the drug of choice is biguanides. We say that PHMB and chlorhexidine. You might have heard and you might have seen the patients with acanthamoeba keratitis using PHMB and chlorhexidine. Right? This is the drug of choice, although they are not FDA approved. So they are being off-label used. And then if anybody needs PHMB and chlorhexidine, where so this is being compounded. So our hospital makes, whereas it is not available in the pharmacies, which is the commercially selling other drugs. So in case anybody is requiring PHM and chlorhexidine for any the patient suffering with acanthamoeba keratitis where they are not finding any medication, please let us know. We will try to help that.
Now, anthelmintics. Different anthelmintics are there: pinworm, hookworm, tapeworm, and roundworm. Pinworm will cause a tinea pedis. Sorry, roundworm drugs are albendazole. What it will do? These all anthelmintics act on beta tubulin. Whenever beta tubulin enzyme will inhibited, rest of the whole process will stop. So that anthelmintic will die. That helminthiasis will die. Like hookworm and pinworm and roundworm, the major drugs are albendazole, mebendazole, thiabendazole, and whipworm and trichinella spiralasis, albendazole, mebendazole. Tapeworms for praziquantel, niclosamide, and albendazole. Hydrated disease, albendazole. So the major drugs is albendazole and mebendazole. Now anti-allergics. This topic we already covered. This topic we already covered in last class also. The agents against histamine reactions. Those are called as anti-allergics. So unwanted or unintended response you will see. Histamine, what is histamine? Histamine is a biological amine which is stored in mast cells and basophils. If you talk about any allergen bind to the Ig, our any Ig and particularly Ig antibody, if you see here how the granulation process will seen, resting mast cell and activated mast cell. Multivalent antigen cross-linked bind to the Ig antibody causing degranulation. Whenever degranulation will happen, allergy will happen. See this how many types of receptor H1, H2, H3. Particularly allergic reactions will in H1 receptor like already mentioned you triple response flush, wear, flinching and urticaria. If you talk about H2 receptor present in stomach, it will causes the ulcers. H3 for we don't know unknown reasons. H4 is treatment for autoimmune disorders. The major different class of drugs are there. First generation mostly lipophilic, second generation hydrophilic. If you talk about first generation, highly sedative drugs, diphenhydramine, dimenhydrinate, promethazine, moderately sedative, phenyramine. Most of these antihistamines are anti-allergic. Major adverse effect is sedation. Because of it will suppress the CNS. So the people will calm down. Then you may get sleep. That's why the physicians also will suggest antihistamine or anti-allergic will take to night times. Then you may get good sleep. The second generations are fexofenadine, loratadine, desloratadine, cetirizine, azelastine, ropatidine. These are the different class of drugs. So drug and therapeutic is their common side effect. Diphenhydramine used for allergic rhinitis. The common side effect is sedation, dry mouth. Dimenhydrinate also used for allergy with nausea, motion sickness. The common side effect is drowsiness. If you talk about promethazine, severe allergic reactions will cause for you use urticaria. Heavy sedation will cause hypotension, hydroxygen, synergin. Synergin mostly used for vertigo. If you talk about dexchlorphenamine, allergic rhinitis, and urticaria, these are all different class. If you know Montlucast and levocetirizine combination, the physician mostly will suggest you take night times because of if you take the drug, too much sedation will happen. If you take about daytime, you can't able to work. That's why they will suggest you to take evening times.
So what is the improvement that they made from from the generation 1 to generation 2 is hydrophilicity. They improved the drug hydrophilicity through some structural changes. Basically, the first generation drugs causes lot of sedation. Why? Because the Kiran told that it crosses the blood-brain barrier. So any molecule with high lipophilicity, basically it is more attached to a lipophilic tissues that we say as a lipophilic drugs, and those kind of lipophilic nature drugs basically crosses the blood brain barrier and binds to those histamine receptors and antagonizes that. So why it causes the sedation when it crosses the blood brain barrier and binds to the histamine receptor present in the brain is because that histamine is very important to maintain the sleep wake cycle. So if you want to wake, so histamine is has to be triggered. So the histamine is one of the important neurotransmitter that helps triggering your brain to maintain the sleep wake cycle. So that's when you halt this histamine H1 receptor, then suddenly the patient always goes to a sleep, or they always feel sedation. That's why these drugs were being recommended to use only at nights, not during the daytime or during the driving. Or so histamine receptor, so like so the predominant histamine receptor present in the eye is H1 receptor. So when you when there is an allergic reaction, so you always give H1 receptor blockers like olapatadine. That basically blocks the H1 receptor present in the eye and controls the allergy. So I think Kiran can now take further.
Yeah. So we already discussed previously what is nervous system. The nervous system is two types. One is central nervous system. Another one is peripheral nervous system. Central nervous system, if you talk about brain and spinal cord, and peripheral nervous system, somatic and autonomic. In somatic, the single nerve is there. Autonomic, again two types, sympathetic and parasympathetic. Also called as sympathetics. There, please carefully listen. Sympathetic and parasympathetic. Sympathetic we will call as adrenergic, and again we will call as fight or flight hormone. Again we will call as diffuse system. If you talk about parasympathetic, cholinergic system, and a rest and digest system, and a discrete system, and it also called as discrete system. So if you talk about any physiological differences, simply we can give one example. There will be you went for any washroom kind of thing, automatically you seen any snake. What is your response? First what you will see, you have, you may feel fear, so your eyes will dilate. That is called as pupil dilation. And what will happen, you were running fast, so your heart rate will increase. So then you need more energy. So ATP consumption is required. That is called as glycolysis and glyconeogenesis, glycogenolysis. And what will happen? You can't able to uh, went for washroom also. So all will relaxed. So you came back. So uterine relaxation will happen, not contraction. Uterine relaxation will happen, and you need more oxygen. So your lungs will expand, bronchodilation, and your peristaltic movement will less, so you can't able to go for washroom, so inhibit the peristaltic movement, and you can't able to go for urine. So your uterine relaxation, that urinary blood you can't go for. So these are the physiological responses if that noradrenaline or adrenaline will release. If you see here, these are sympathetic nerves. These all are the physiological responses. If you talk about parasympathetic, that acetylcholine, whenever acetyl, I already mentioned you, rest and digest system. It will be a cool and cool time, like eating, simply SLUDD, salivation, lacrimation, urination, digestion, defecation. These all are in a calm. While eating is good, and while sleeping is slowly, and while these are the different kind of and one more thing is constrict your pupil, constrict, slow heartbeat. These are the different kind of physiological responses. What are the therapeutic uses for cholinergics? The agents which act mimic just like acetylcholine, muscarinic uses and nicotinic uses. Glaucoma, we already discussed glaucoma, pilocarpine, physostigmine, and Alzheimer's. What Alzheimer's? Alzheimer's is a dementia, looks like dementia. What will happen here? This is a neurological progressive neurodegenerative disorder. Pyramidal in brain, pyramidal tracts will damage. Then Alzheimer's will occur. For the best treatment is tacrine, donepezil, galantamine, and rivastigmine. If you talk about Sjogren syndrome, pilocarpine and cevimeline. It's a Sjogren syndrome, also called a dry eyes disease. And belladonna poisoning, if for antidote is physostigmine, and you can take it as atropine also. And post-paralytic ileus, you can use bethnicol and neostigmine. Urinary retention, you will use bethnicol and neostigmine. If you want to check bronchial hyperactivity, whether if somebody patient having any asthma, you have to check how much he having his tidal volume. So methacholine is the best drug for checking of bronchial hyperreactivity. If you talk about nicotinic uses, because of in cholinergic we have different types of receptors, muscarinic receptors and nicotinic receptors. In nicotinic also nicotinic neuronal are there, nicotinic muscular are there. Muscarinic receptor M1 to M5. If you talk about nicotinic receptor, mostly neuromuscular junction. We will talk about myasthenia gravis. In nicotinic neuronal receptors like these reverse skeletal muscle relaxants, neostigmine, pyridostigmine. What is myasthenia gravis here? Severe weakness of muscle. Mya means muscle, asthenia means severe, gravis means weakness. This is the severe weakness of muscle is called myasthenia gravis. The best drug is myasthenia gravis is neostigmine and physostigmine. But if you want to diagnosis for myasthenia gravis, you can use the hydrophonium. And cobrabite antidote is neostigmine and pyridostigmine. Anticholinergics, these are the drugs act against cholinergic reactions, like whatever we taught previously. So the all actions will stop. Like natural alkaloids are atropine, hyoscine, semi-synthetic derivatives are atropine, methonitrate, homoatropine, and synthetic compounds are like cyclopentolate, tropicamide. If you went any eye hospital, if they want to check your eye properly, means what are the eye function, like what is the sight of range, is there any defect in your eye, they will check. They will add one midriatic like cyclopentolate, tropicamide. What is midriatic? Pupil dilation is called midriatic, constriction of pupil is called miotic. These are the drugs used as midriatic, cyclopentolate, tropicamide. And the viscoselective drugs are oxybutynin, flavoxate, tolterodine. And anti-Parkinson. If you see what is Parkinson, Parkinson also progressive neurodegenerative. What will happen here? Dopamine levels will reduce. If you want to treat Parkinson, you have to increase the dopamine levels. This trihexyphenidyl and procyclin, it will act, it will improve the dopamine levels. And anti-secretory or antispasmodics, quaternary ammonium compounds like propanthyline, oxyphenonium, clonidinium, and tertiary amines are dicyclamine and valtamate. And adrenergic drugs and anti-adrenergics, these all we already discussed. What are adrenergic actions? So pressure agents like ephedrine, dopamine, phenylephrine, nafazoline, these acts as just like bronchodilators. And we used to as bronchodilators also isoprenaline, salbutamol, terbutaline. The salbutamol and terbutaline will act on beta 2 receptors. It will causes the bronchodilation. These ephedrine, norepinephrine, these noradrenaline, these will act on alpha 1 receptors. If you talk about cardiac stimulants, whenever cardiac arrest will happen, adrenaline, isoprenaline, dobutamine will give. Nasal decongestants. Now, what is nasal decongestants? It will remove the congestion. Wherever blockade happened in our nose, it will reduce that blockade. Like xylometazoline. You've seen all about Otrivin nasal drops. That is containing xylometazoline and nafazoline. And CNS stimulants are amphetamine, dexamphetamine. If you want to use uterine relaxation, ritodrine and isoxopride, and anorectics, amphetamine and fenfluramine. Alpha adrenergic blocking agents are these are the different class of drugs. These mostly used in and alpha adrenergic blocking agents in hypertension. The finally last but not least here miotics, and I already mentioned what is miotic. Constriction. If you see here diagram, the pupil size is constricted. So constriction of pupil is called as miotic. The best drugs are pilocarpine and physostigmine. If you talk about mydriatic, dilation of pupil, if you see here, dilation happened. Those best drugs are atropine and scopolamine. So these mydriatics mostly used in eye checkup. So the next topic will cover by Monique.